Thank you, Dr. Chow. Good morning, everyone. Thanks for joining us with the St. Michael's Hospital Echo Rounds. I'm Nicolas Santi, one of the cardiology residents here in Toronto, and the topic today is Holes in the Heart, VSD VSR edition. I have no disclosures related to this talk. And the objectives for today's talk are to review the epidemiology and anatomy of VSDs, review echocardiographic assessment of VSDs, discuss the management considerations, and go over some similar objectives with a focus on ventricular septal rupture. In terms of epidemiology, congenital heart disease prevalence is about 8 to 9 in 1,000 births, and VSDs are the second most common congenital heart disease in about 25% of all patients, and that's only after bicuspid aortic valve. About 10% of adult congenital heart disease, however, is VSDs because most of them close spontaneously during childhood, and many are addressed surgically with closure during childhood. About 5% of patients with VSDs have chromosomal abnormalities, which can include trisomy 21, 13, and 18 syndromes. There can be a single VSD defect or multiple defects or single defect with multiple outlets, kind of like a Swiss cheese pattern. And they can be isolated or part of complex congenital heart disease. There can also be acquired VSDs, including ventricular septal rupture in the context of a myocardial infarction. And there can also be iatrogenic VSDs, which is all the more relevant in the era with increasing valve intervention possibilities. And these can happen after surgical or even transcatheter valves, classically aortic valves, but can also occur from erosions from struts, from mitral valve bioprosthesis, and of course with cases of septal myectomy for hypertrophic cardiomyopathy, as well as cases with alcohol ablation. In terms of clinical context and clinical consequences of having a VSD is the finding of progressive, if the shunt is significant, progressive left atrial and LV dilatation failure and pulmonary hypertension. And this is from volume overload from the pulmonary venous return. The dilatation of the left heart, left atrium, can also lead to functional MR in some cases. Having a VSD increases the risk of endocarditis in the patient. There's also increased risk of heart block, although this is all the more increased in certain types and if closure is required. Arrhythmias are more common than the general population, however rare in comparison to most congenital heart diseases. Some of the more complex things that can happen in terms of consequences of having VSD is actually the development of a double-chambered RV, or DCRV, which is a thickened area of RV endocardium, sometimes from the septum, sometimes a muscular band, which results from the high velocity jet, and can actually, with time, lead to progressive RVOT obstruction. This is predominantly seen in perimembranous VSDs and can also, interestingly, occur with residual jets with high flows, one would imagine, which is part of the reason why it is important to continue to follow these patients even after closure, and more often if there's a residual jet. There can also be a complication of aortic cusp prolapse, mostly in outlet VSDs or perimembranous VSDs, and this can lead to progressive aortic regurgitation and dilatation of the sinus of VALSALVA, causing aneurysm, which can in its turn rupture, and we'll get back to that later in the presentation. So some of the clinical presentation, I apologize for the busy slide here, but it is some key stuff. Most patients that we will see in adulthood present asymptomatically if they have a small defect with a pansystolic murmur, classically at the left lower sternal border, which is harsh and louder if the defect is small, higher gradients if the defect is small, and often a palpable thrill. But this finding is modified by the consequences of the VSD, whether you develop pulmonary hypertension, Eisenmenger syndrome, aortic insufficiency. The position of the VSD can also affect the location of the murmur and so on. Small defects previously have been defined as less than 5 millimeters, moderate 5 to 10, and then large greater than 10. But there's sort of been a shift in terms of that definition to discuss the percentage of the aortic annulus that the orifice takes up. So less than 25% in terms of the size of the orifice would be small, 25 to 75 moderate, large more than 75, but it also includes the shunt volume, and that's what that QPQS is the flow of the pulmonary circulation to systemic circulation. And if it's less than 1.5 to 1, considered small. And again, small defects usually have normal pulmonary artery systolic pressure and are usually asymptomatic. In moderate defects, QPQS 1.5 to 2 over 1, there's often mild to moderate overload of the pulmonary artery and left-sided chambers. And children with this may be asymptomatic for quite some time or sometimes develop heart failure later in childhood. Often this can resolve with medical therapy, actually, as the VSD continues to close with age and time. And if that's not the case, then usually closure is indicated, particularly if there are findings of overload. And then finally, large defects, which are defined as QPQS greater than 2 or with pulmonary hypertension, leading to heart failure, most oftenly require closure in the first year of life. They can progress with pulmonary arterial hypertension, which then increases the volume, decreases the volume of the left to right shunt, which decreases as the pulmonary vascular resistance increases, and eventually develop the Eisenmenger's complex with the right to left shunt. Eisenmenger's complex can also be present soon in the neonatal period if the right side pressures do not fall after birth. So sometimes the surgery is required sooner, and of course is dependent on the other congenital findings that go along with this large VSD defect, which often is the case in these situations. You'll hear the term restrictive in some of the readings you may do on the subject, and what this is it's not a anatomical type. It is a classification of what I like to think is a more benign VSD. So this is a small defect with high gradients, with a small shunting volume of a QPQS less than 1.5 to 1, and no pulmonary hypertension findings. These types of defects can be observed according to the AHA-ACC guidelines in absence of infective endocarditis, aortic regurgitation when the defects are membranous or muscular. And we'll come back to that as well. So the echo features of a restrictive VSD include normal left-sided chambers, absence of pulmonary hypertension, and a high peak gradient, which has been defined as greater than 64 millimeters mercury. There are 4 main types of VSD, and this often leads to a bit of confusion because different publications and over time have used different names for them. So I've tried to reconcile that as best I can for you here. You'll notice that they're slightly out of order. I've repositioned them with perimembranous at the very top because this is really the most common one, as you'll see. But there's the STS, EACTS types. Perimembranous has also been called membranous. There's outlet, which has also been called infundibular or subarterial or supracrystal. There's the inlet VSD. This is the AV canal type. And there's the muscular, which is the second most common type. And these are based on the position of the VSD on the interventricular septum. And originally the view was considered from the surgical view of the right side. And that's where the original STS, EACT types and naming come from. And we'll go over those in more detail. There's sort of an unofficial fifth type, which is known as a Gerbeau defect or a Gerbud defect, which is the least common. And this is a defect between the septum of the left ventricle into the right atrium. So causing a left ventricle to right atrium shunt. Can be congenital or acquired. And this is just an image from Flores et al. To the right here, showing you this is actually a modified subxiphoid view that they have if you're a bit lost, and you can see the defect there. This is a quite helpful table. I find that the use of this is great because it shows you that anatomical look at the breakdown of the septum. The trabecular septum is, of course, the muscular part. There's the inlet into the RV and the outlet of the RV, and then the small membranous component of the septum for this classification. And it shows you around the views that you would see on surface echo and try to correlate those different anatomies to what you're seeing. So we'll come back to this slide again as we look at images because I find it to be quite helpful. So in terms of the different types, there's perimembranous, which is the most common, as we've said. It's located in the membranous septum between the aortic and tricuspid valve, and it borders the septal leaflet of the tricuspid valve. As you can see in the prior figure in your top right, on the short axis view, it's that little yellow band there is where they're commonly found. They, however, can extend into the RV inlet, outlet, or trabecular portion. So it's a bit of a, not a misnomer, but a bit of a hook out of left field to say that they're completely isolated. They can often extend into the other sections, the other types. And these VSDs can be associated with the double chamber RV that I mentioned earlier, with or without RVOT obstruction, which can be progressive. And of course, prolapse of coronary cusps, which can lead to progressive aortic insufficiency, hence the need for monitoring, as well as sinus of VALSALVA aneurysm. However, this last complication or consequence, let's say, is often more common seen with outlet VSDs. So here's the first case. We have an asymptomatic young adult with a loud holosystolic murmur since childhood. And let's see what we have here. So hopefully this image is playing for you all. For time, I'll just go through it briefly. This is a peristernal long axis view. And if I can, if you can believe in the eye of faith, I'll point to the septum where you have a bit of a sigmoid septum, and just below the aortic valve, you can see that there's maybe a little defect there opening up. And what I'll do for you, as you've of course requested, is I'll put some color on that. And you can see that the color reveals that there is some shunting there, and you can see the high flow in the RV, which is a bit of a giveaway. This is a peristernal short axis view. That's a little bit off axis. That's why the aortic valve looks unusual, and you're having trouble determining the amount of leaflets there. And as you can see, near the border of the tricuspid valve there, that's a little bit hidden, there's that flow coming through and then moving onwards into the RVOT. So fairly classic. So case one, this patient had a left to right shunt with a very high peak gradient of 180 millimeters mercury and a calculated shunt volume ratio of less than 1.5. Patient had normal left atrium LV and no pulmonary hypertension. And there were, of course, no complications of the VSD, such as a sinus aneurysm or AI, no history of endocarditis, and patient was asymptomatic. So this was deemed a restrictive small perimembranous VSD, and this was observed. And of course, the patient comes back for echoes and clinical monitoring. The next type is the outlet type of VSD, also known as supracrystal. It's about 5% of VSDs. However, it is important to note that it is more common in Asian patients and less common in European patients. So make sure not to miss that. The location is between the semilunar valves and the outlet septum of the RV, and it's adjacent to the aortic and pulmonary annulus. It can be associated with early pulmonary hypertension development because the flow is often directly into the PA. And in up to 50% of these, they can be complicated by the coronary cusp prolapse, which we've talked about, which can sometimes occlude or partially occlude the defect. So you can actually miss the VSD itself with just color, and you do have to look at the anatomy. And sometimes it can also lead to, as we said, progressive AR and aneurysm of the sinus of Valsalva, which causes its own issue. So again, here it's that green segment. It's very close and in continuity with the perimembranous area, as you can see in the peristernal short axis as well as peristernal long axis. One of the views that helps distinguish the two, other than the position on the short axis, is also looking at your 5-chamber view, where you should see the perimembranous, but you will not see the defect itself for a pure outlet VSD. One of the things that we have to distinguish is a VSD versus a ruptured sinus of Valsalva, which can be mistaken for this, are very close to each other. And the way to differentiate is that in VSDs, the flow passes below the aortic leaflet, and the flow is confined to systole on your Doppler for the most part. In a ruptured sinus, the flow passes through the wall of the aorta and is continuous with a high velocity diastolic component because the jet origin, of course, is aortic. Some of these caveats is that they can occur, both occur in the same patient. Often the dilatation is caused by the VSD, which then can lead to rupture. So you can keep that in mind. This is a figure from Kim et al. Showing a ruptured sinus of Valsalva aneurysm. And they've highlighted here in the Doppler profile the diastolic component, which is the ruptured sinus of Valsalva aneurysm, RSVA. And this patient also has, and the flow is also showing a VSD component in systole. If you look at the ECG tracing and trying to situate yourself, this patient has quite large P waves compared to the QRS. So you can see there that the RSVA flow is occurring in diastole. And this is a case from the St. Michael's Echo Lab. And this person had, this is a 5-chamber review, and this person had a mechanical aortic valve repair and then was found to have a sinus of Valsalva rupture to the RV. And I just wanted to show you what that looks like. You can see it there, the presence of the mechanical valve, and the flow really is in the aortic component of the heart as opposed to below it. The third type is the inlet VSD found in the inlet septum. It is a form truly of AV canal defect. I think a picture is worth 1,000 of my words, certainly. At the bottom right corner, you can see how these manifest, and they are as they appear here on echo. There's two types. The partial involves the valve apparatus itself being adjacent, connected to the ventricular septum, and it actually obliterates the VSD component. And otherwise, these are quite associated with cleft anterior leaflets of the left-sided AV valve. Certainly, they can be seen in some of the chromosomal abnormality cases we discussed earlier, and these require surgical repair in early life. They are exceedingly rare to see in adulthood. I talked to some of the echocardiographers in the lab, and they have not had them come through unrepaired like this, obviously, because of the significant cyanosis it causes in early childhood overall. And then finally, type 4, which is the second most common type, the muscular type. This is completely surrounded by trabecular muscle. There's frequently multiple, so it's important to look for them. Even if you see one, keep sweeping, keep searching, because they can be hiding. And frequently, again, the size decreases with time, often spontaneously closing in early childhood. They are considered to be easier to miss, particularly when they're hiding in the apical regions. And so sweeping at multiple angles and levels is quite helpful with that. And then we, of course, have the ventricular septal rupture, which is a life-threatening mechanical complication of MI. In the pre-PCI era, it was about 1 to 3% of MIs, and now it's less than 0.5% or so with revascularization with PCI. They present in a bimodal distribution, with most of them either within the first 24 hours or around day 3 to 5, and very rarely after 2 weeks. Some risk factors for the development of a VSD include delayed or no revascularization, advanced age, first MI and no history of angina, heart failure, being female, and hypertension. When you're scanning them, when you're looking at them on echo, look at the infarct or regional wall motion area border with the normal or hyperdynamic tissue. Often they are found there, and they can be associated with, of course, aneurysm, free wall ruptures, heart failure, cardiogenic shock, and so on. Anterior MIs often cause apical septum defects, and inferior lateral MIs often cause basal inferior posterior septum defects, as you can see in the classic pathology image from the New England Journal at the bottom right there. Very, very nasty in appearance. The infralaterals are of higher reported mortality and are more challenging to close. The management, I won't dwell on this too much because this was touched upon in the echo MI presentation earlier in the fall, but essentially the acute considerations are afterload reduction with mechanical support, balloon pump, nitroprusside if BP permits, and diuresis, and you're talking to your surgical team about closure. And in very select cases that are not for surgery, percutaneous closure can be considered, and certainly has been done, including at St. Michael's Hospital. In terms of the echo, our job with echo is to make sure that we identify the defect, the type and the location, any coexisting congenital abnormalities, hemodynamic consequences that we talked about, obtaining the gradient as well as the shunt ratio assessment, your QPQS, and of course post-closure follow-up. Some of the post-repair assessments, so you're looking at the biventricular size and function, you're assessing for pulmonary hypertension in the ways that you usually do, and one more way that we'll talk about later. You're looking at valve function, particularly the aortic valve, if surgical repair had to happen, and you're looking at screening for the progressive development of subaortic or subpulmonic stenosis, like the DCRV we talked about earlier, which can continue to progress when you have a residual defect with a high gradient. And of course, residual shunt assessment, also relevant for infective endocarditis prophylaxis, as seen in the AHA guidelines. In terms of timing of follow-up, the European Society of Cardiology recommends that a small restrictive VSD that has no other lesions, has normal left-sided chambers and pulmonary pressures, and are completely asymptomatic, can be followed in a 3 to 5 year interval. However, patients with anything more than that should be seen every year, including evaluation in a specialized adult congenital heart disease center. For our second case, we have a case of a penetrating chest wound, and it's now status post-CV surgical repair. I don't have more details for you than that. However, the patient in the hospital remains in clinical heart failure, and the repeat echo shows the following. So here we have a beautiful sweep, and again, making sure to put color at the apex here, reveals a ventricular septal defect or potentially rupture in a post-operative state. And we can see clearly that there is left to right shunt there. This is the apical 3-chamber view zoomed into the apex for your consideration. And so for this patient, because of the moderate size defect, I believe the QPQS was 1.7, 1.8 or so, and the patient was in clinical failure that was thought to be related to this with higher pulmonary pressures. There was device closure was decided because they had already undergone cardiac surgery, and it was felt to be the safest thing at this time. So the patient had device closure and a follow-up. This is the echo from follow-up. So looking at the left side, hopefully, there we go. Looking at the left side, we have Anplatzer-like closure device seen zoomed into the apex there. Quite beautiful view. And on the right side, we see, if you can see, the device is there, but there's a small residual shunt there that you can see with the color Doppler. This is the spectral profile with continuous wave Doppler, and you can see that these are quite high velocities and therefore high gradients, suggesting that this is likely now residual shunt being more restrictive in nature. And of course, all the other chambers were assessed, pulmonary pressure was assessed, and this was felt to be restrictive, and so the residual shunt will be followed. So since we've talked so much about shunts, let's talk a little bit more about the QPQS shunt ratio. And this can be, of course, and should be attempted to be estimated via echo, but this requires adequate visualization for the outflow diameter measurements, and the Doppler alignment should be parallel to the flow for adequate VTI for the stroke volume calculations. Commonly, cath and MRI are used and are more reliable. If there's any uncertainty with this calculation with echo, or if visualization is inadequate, or so on, or if there's any suggestion of pulmonary hypertension when you do the echo, then please send them for cath. And again, they should be assessed at an expert center. I think it was Dr. Connolly who suggested that I try the St. Mike's 1-to-1 challenge. Take a normal study and see how close you can get it to 1-to-1, and you'll see yourself some of the difficulties and pitfalls with these measurements if you can't get a good look at the RVOT or the PA for these measurements. And of course, nothing is perfect in life, so it's worth a try of this simple exercise. So Q is the volume of blood flow, which is essentially the stroke volume. And stroke volume is the cross-sectional area times velocity time integral, which we're used to doing for the aortic valve. And of course, the cross-sectional area is dependent on the diameter, which you'll measure. QP is the pulmonary flow that can be assessed at the RVOT or the PA. And again, there's caveats if there's any obstructions. And then it's also been described that you can do it at the mitral valve, which is sort of considered the outflow of the PA. But again, that complicates things when there are different obstructions along that path. Finally, QS is the systemic flow at the LVOT, as you're used to calculating and obtaining for all your echoes. Again, a shunt greater than 1-to-1 is a predominant left to right shunt, with a shunt of less than 1.5-to-1 considered small. QP/QS of less than 1-to-1 is predominant right to left shunt. And finally, if you get 1-to-1, you either have equal shunting or no shunt at all if there's no defect, of course. And that's hence the challenge is worth a try with one of your echoes to see what you get. This is some images taken from the Canadian Society of Echocardiography website. Nice illustrations that show you, again, what we were talking about. We'll start on the right side, which is what we're all used to seeing in the parasternal long axis view. You can see where you take your diameter measurement of the LVOT, and you're making sure that you have your pulse wave Doppler at that exact area where you're taking the diameter measurement to then trace your integral for the VTI. Then the same thing can be done at the RVOT. This is shown in parasternal short axis, again for the diameter and Doppler and VTI. And then sometimes if the visualization is better in the PA, that's been described as well and was one of the first descriptions of how to do this. And then finally, we can also estimate RVSP, which you should be doing, obtaining an RVSP. And of course, you can rely on your usual friend down below using the TR Vmax, but sometimes we don't have enough TR for this. And so you can actually calculate the RVSP using the VSD peak velocity in the formula provided here using the systolic blood pressure. Now, there's a lot of caveats to this, and if you have a restrictive small VSD with a high gradient, you'll see that it's less reliable with high gradients, often overestimates the peak velocity in high gradient, more so in sort of longer, narrower tunnel-like VSDs for different reasons. And if you're interested in reading more about it, there's an interesting paper from CANAL that I've cited there for you. And then some of the other caveats is that you should be trying to take the blood pressure, the systolic blood pressure, at the same time as you're doing your Doppler, and not just at the beginning of the study, which can be, 20 minutes before that or 10-20 minutes before that, because your blood pressure is so changing. So it's worth taking them at the same time if you're going to be attempting this, and you should be attempting this, and particularly with the moderate and large defects, this is all the more relevant and related to your decision of closure. Again, if there's difficulty in obtaining this via echo, it's worth, if there's any question, to do it with cath plus or minus MRI. And this is my defacing of a beautiful table, and I apologize, I added the black so that there wouldn't be any confusion, so that your eyes would not be drawn to the ASD closure recommendations. But this is a great table from Asenza et al. That was recently published in November in JACC, and it's a comparison of the main guidelines for closure decision. And they're looking at the AHA-ACC guidelines from 2018 versus the European Society of Cardiology guidelines from 2020. And as you can see, the table below, we're looking at VSD or PDA closure. And essentially, the Europeans will rely on pulmonary vascular resistance, looking at Wood's units, versus American guidelines talk more about the ratio of pulmonary artery systolic pressures to systemic artery pressures or vascular resistance. And the mainstay of this is that you want to be closing significant shunts with QPQS more than 1.5 or evidence of LV overload before they get to the so-called point of no return, Eisenmenger physiology, or very high pulmonary vascular resistance above 5 Woods units that are also desaturating on exercise, or as the Americans would say, a net right to left shunt with significantly elevated pulmonary pressures and resistance compared to systolic. I spoke a little bit with one of our friendly neighborhood interventionalists ahead of this talk about closure, and some of his insights were that it is exceedingly rare to have closure of VSDs in adults. It is done mostly for muscular and sometimes perimembranous. Usually if they have any evidence of left chamber overload or history of endocarditis, closure will be done. And of course, there's a higher preponderance after closure of heart block and perimembranous VSDs. And then of course, they close VSR defects after MI in select patients. And so those are some of the practical considerations around these cases. This is case number 3, to the point I made earlier about acquired VSDs in this era. So, and in all times, this person had a bio-AVR, and then this is the echo here. So again, a parasternal long axis view. And looking at this, you can see that there's a prosthetic aortic valve. It may be a little low, but hard to say for sure. Don't see anything obvious necessarily with just the 2D Doppler. And once you apply the color, you can see that there is a defect there in the membranous septum and high flows, again, in the RV, which is a bit of another potential giveaway of the shunt, which should draw your eye to the septum and to other potential shunts, which we won't discuss today. And so this patient, we're now looking at the parasternal short axis. As you can see, once again, similar to that first case we showed, next to the tricuspid valve, there is a perimembranous VSD. You can see the flow going into the RVOT. So certainly, we sometimes think about the rarity of significant VSDs coming from the congenital population to adulthood, but we can't forget the importance of thorough assessment after valves, particularly aortic, as they can cause these defects with similar consequences. This is the same patient, and this is I just wanted to highlight the massive flow that you're seeing with the color in the pulmonary artery, which again, this is what leads to the volume overload on the left side of the heart and the classically left-sided dilatation and eventual failure, as opposed to an ASD where there is dilatation of the right chambers. This is the same defect seen in the apical 4 chamber. You can see that there's flow in the right ventricle, but we're not quite seeing the full defect or flow across the septum. And this is classic of a perimembranous VSD. And to bring it out, you're going to angulate into the 5-chamber view. And so this is the 5-chamber view there. And now we clearly see, once again, that there's flow entering the RV, but we see it also across the septum itself. This is the Doppler, continuous wave Doppler across the defect. I believe this is the subxiphoid view, and you can see again that these are sort of a high but somewhat moderate to high peak gradient, about 80 millimeters mercury across this defect here. And then case number 3, we had a bioprosthetic AVR, which then led to an iatrogenic perimembranous VSD with left to right shunting. And the QPQS was calculated at 1.7 to 1. The prosthetic aortic valve was deemed to be well seated. And so they moved on with this, but there was required closure due to the significant shunt. Some of the key take-home objectives. So we talked about the review of the epidemiology of a VSD. Again, the second most common congenital heart disease. Look for the different types. Look for acquired after AVR or myectomy. In terms of echocardiography, sweep and color are your friends. Look for the hemodynamic consequences and associated defects. And in terms of the review management considerations, there's the HAESC guidelines for closure and for other management. You're making sure that you're calculating your QPQS and looking at, again, the hemodynamic consequences, which are guiding your decision for closure, as well as remembering about infective endocarditis prophylaxis for residual shunts or cyanotic disease. Similar objectives were discussed, although briefly, for ventricular septal rupture. And again, look at the regions of thin dyskinetic myocardium. The management includes acute afterload reduction and closure. Thank you very much. There's time for question and comments, but since we've finished a little bit early, I just want to take you to one more slide for a discussion of the pressure changes and the Doppler, and then we'll come back to questions and comments. These are some of the references. And this is, again, I think worthwhile having somewhere around you when you're assessing these to decide exactly which anatomical type of a VSD you're dealing with. So these are some of the Doppler considerations, and we had a good discussion about this in the Echo Lab. So according to the Auto textbook, Doppler ultrasound has a sensitivity of about 90% for detecting these, and really that's the importance of sweeping, really looking at the apex, which our sonographers do a great job of at the lab, and a specificity about 98% overall. But the sensitivity has been described up to 100%, again, depending on if you know you're looking for it, which often you are when you're referred a patient for echo with a high-pitched, high-flow, loud murmur. Continuous wave Doppler ultrasound shows a high-velocity left-to-right signal, and the shape of the curve is similar to that of the mitral regurgitation. And interestingly, of course, in diastole, the left-to-right shunt persists at a lower velocity, and this is proportional to the diastolic LV to RV pressure differences, which is different than what we talked about with the sinus VALSALVA rupture, where you have these high velocity shunting in diastole. There can also be brief reversal of flow, which can sometimes, but not always, occur during the isovolumic relaxation and contraction phases. But both the brief reversal of flow, which can sometimes occur, and the persistence of the left to right shunting in diastole are both very brief and not appreciated unless you have a low high pass filter setting on the Doppler. So you probably won't see it with your usual Nyquist limit. And again, because of these considerations, because of the reversal of flow often does not happen, a bubble study is significantly less sensitive for the detection of an intracardiac shunt at the ventricular level compared to looking at an ASD or PFO. And finally, can't have an echo presentation without at least mentioning TEE, which is useful certainly for the assessment of other structures and defects, as well as surgical planning when you have these defects. Very helpful for the 3D assessment, which can help assess the actual size of the VSD and its borders. So I'll bring you back to my thank you slide, and thanks for coming. I'm glad we finished a little bit early, so we have time for a little bit of discussion. Any questions or comments? Thanks, Dr. Chow.
So thank you, Nick, and thank you for all the participants. So I'll just make a couple of comments. So this is one of those situations where we highlight the importance of examining the patient before you actually put the probe on, because then you can try to make a decision ahead of time what you're looking for, because sometimes they could be elusive when you're not like tilting the right directions, and sometimes they can be missed, especially for the non-restrictive ones. So that is may, I think for the trainees, it's really worthwhile to examine your patients before you put the probe on, so that you can mentally try to see what kind of lesions you're looking for, or at least try to like figure out all the valvular lesions and the degree of severity perhaps, and also the RVSP, and like prior to actually put the echo probe on. So that's a very, very good exercise to do, especially now with COVID. It's really hard to find patients to examine. So Echo Lab becomes a great place to hone your physical exam skills. Another historical comments, I was just talking to Nick prior to starting. There is a distinction between Eisenmenger disease and Eisenmenger syndrome. So Eisenmenger disease was actually described by a German physician, Victor Eisenmenger, in the late 1800s in a young man who has ventricular septal defect with reversal of shunts. And then Eisenmenger syndrome was described much later on in the, I believe, early 1900s by Maureen Mott Abbott from McGill University, who's a student of Osler, one of the first women physicians in Canada, to describe reversal of shunting, right to left shunts, among any congenital heart disease condition. So just there's a distinction between Eisenmenger disease and Eisenmenger syndrome for your own historical interest. So let's open this for comments from participants and colleagues, and comments and questions. Scanning tips from sonographers. The scanning of this is really important to be able to tilt and also do all the panning around the lesion, so you can see the extent and where it goes, etc., and try to catch the largest jets.
Chiming, it's Bob.
Hi, Bob. Good morning.
Hi. I guess a comment just to say with the perimembranous, the infracrystal, supracrystal, I guess my experience is the short axis view is probably your best view to try to see them. I must say the parasternal long axis view, you know, they're usually not there. They're usually just off. So our typical parasternal long axis view, it's hard to see them. And the short axis view is the nice one, and obviously helps you differentiate between the infracrystal and supracrystal, as shown on, you know, the green and the yellow here. So that's the view that I think, you know, for those which are the common ones you want to look at. I guess the other interesting thing that can happen is some of the infracrystal ones, the yellow there, will close over time, and the septal leaflet of the tricuspid valve can, for whatever reason, sort of stick down and actually close them off, and it'll often, they'll leave them with what looks like a little aneurysm, but if you look closely, it's really made up of the base of that septal leaflet. So it can be a little aneurysm there, and sometimes there's still a little wee leak, but feeling is that some of them can close on their own.
Yep, indeed, I like the short axis for this. Thanks for highlighting that.
I guess the other comment is the sinus of VALSALVA rupture. You know, it's a very short distance between above the aortic valve and below the aortic valve, and sometimes you really have to sort of carefully scan up and down, sort of sweeping, to kind of make up your mind whether the VSD is above or below the valve. Obviously, if it's above the valve, the flow should be continuous. and that's the major clue. But certainly, if you were to have both, it's not easy because the distances here are, you know, millimeters. They can be very close together.
That's why having a good sonographer and also physical exam before to know what you're looking for, and panning up and down, and sometimes off-axis views as well to try to delineate that and chase the flow, so as to say.
Certainly, and actually, I think the second case we showed today was to really see the defect and where the jet was emanating from. Our sonographers had to go off-axis in the parasternal short, so that's a great point.
Okay. Any other comments?
One question. Well, just one question for Nick. You made the point. I think it's a good one that with VSDs, the left, you know, with big ones, at least substantial ones with substantial shunting, the left ventricle, left atrium are large, and the right ventricle is not. So why isn't the right ventricle enlarged, Nick?
Yeah, so that's a great point. Thanks, Dr. Howard. So initially, because of the position, most of the shunting goes directly into the pulmonary artery in the vast majority of these. And so that volume overload really goes directly to the left heart. And so you get dilatation from volume overload of the left heart. That being said, with time, with pulmonary hypertension and the remodeling that comes with it and increased pulmonary vascular resistance, the right heart will begin to fail. And eventually, as those pressures equalize and rise in the right heart, you will move towards that Eisenmenger complex that we talked about. So it really has to do with the position and the flow going really directly into the PA. And actually, you can really see it in a way. Let me play this here for you guys. You can just see the tremendous amount of flow here going into the PA. And that's why I wanted to show this clip here. And that's really one of the tipping points that you should be looking around for something, is you're seeing all this excess flow going into the pulmonary artery. So that's a really good point, Dr. Howard. Thank you.
Yeah, so it's actually the flow is during systole, and it basically the right ventricle is contracting, and all of the flow is going in systole out into the PA. So in my mind, it may be that the right ventricle is a little wee bit dilated, but not dilated enough that it would, you know, measurably enlarge. I mean, if the flow goes into the right atrium, then the right ventricle is seeing a diastolic increase in flow, and therefore it dilates. But this is systolic flow, so the right ventricle doesn't really dilate at all in these settings. So sometimes when I ask trainees, you know, there's a VSD and they're kind of not sure why the right ventricle isn't big. It's because it's all systolic and it gets ejected immediately.
That's a great point. And I guess the one caveat to that is the Gerbeau defect that we mentioned, but really that's because it's shunting into the RA, which to your point would then release in diastole in the ventricle.